see a life after this, and you will too. Change the channel. This is the most important one. Change the channel. Stop watching MSNBC talk about the same things over and over again. And I'm not speaking to you in this moment. I'm speaking to myself because I will consume all of the information about a thing that I'm worried about until I'm blue in the face. And it does nothing to come up with a cure or vaccine. It just fills us with angst that we don't need, that is not necessarily useful. Now, of course, there are other examples and useful tips in this moment, and I invite you all to put them into the share box because we want to learn from them as well. Now, it is with pride and pleasure that I introduce this next beautiful human being to the mic. I'm used to introducing him to stages. Michael Lamb is an award-winning poet. Ms. Mikey also uses his talent. Can I get everybody to mute their phone? I'm sorry, I can't. Oh, this is Mikey's music. I'm sorry. Mikey Lamb is an amazing poet, an amazing advocate. Uses his voice, his experience, his mastery with the pen to not only elevate communities, but to raise a mirror to the behaviors that are not moving us forward. I could talk about this brother all day, but I will call him up without any further ado, Miss Mikey.
Hi, everybody. Can you hear me? Okay, cool, awesome. So it is without further ado that I introduce myself just as that introduction did from my brother, Larry Scott Walker. Brothers got this complex complexion, petitions and protests for his death, riots and rallies for his memory, broken hearts and marches for his life, chalk outlines of childhood friends down the road and through the river bend. It doesn't seem to end. His melanin, who he loves, is a sin. Prayers fall on deaf ears when it comes from a sinner's heart. What happened to understanding and compassion for one's journey aside our own? We all experience pain, but not everybody's is the same. A chain is only as strong as its weakest link, yet the squeaky wheel always gets the oil. So what do we do for the brother that can't call on me when he needs a hand? Because his are tied. He dies. Same story, different headstone, black boy, white casket, people steady asking what happened. He fell through the cracks. Thank you all so much for allowing me to join you on this amazing virtual stage. You all are taking the time out of your day to not only connect, but also take these connections to organize and then move forward in this pandemic. So I'm going to start off with this quote by James Baldwin. I love America more than any other country in this world. And exactly for this reason, I insist on the right to criticize her perpetually. And I just want to build on this quote because where there is room for critique, there is room for correction and then coordination to bring those corrections to manifest in order for change. And again, today we are definitely building connections between communities. So, thank you for the next slide. Here is thebody.com. It is the HIV resource on the World Wide Web. I'm a contributor to them, and I was asked to join this conversation simply because of my experience with linkage as a person living with HIV, diagnosed December 19th, 2012. I moved from Florida to Atlanta, Georgia to kind of get away from advocacy and just focus solely on my art, but because of the presence of the work that needed to be done in Atlanta, Georgia, I decided to join a few networks and really use my voice to advocate for change in the Deep South, where HIV numbers amongst Black queer men are completely outrageous. And this article basically discusses my linkage issues and what I found to not be such of the best practices. as far as communication between organizations. We, as people living with HIV, your colleagues and possibly your clients and members of your networks are going to multiple places to only end up seeing one doctor. So they have to get their Ryan White filled out. They have to make sure housing is okay. They have to make sure their food supply is good. They go to pantries. They have to catch, their public transportation. And depending on their location of residence, that may be a strenuous walk. I know living in Atlanta, to get to my doctor's appointment, I had to take 2 buses and a train and walk half a mile. Shout out to the MARTA though. So that is a barrier to care, and also misleading information because of that lack of communication between organizations. When I'm going to different places and getting different messaging, it is not only frustrating, but it creates a fear and anxiety of, what if I don't get my meds? What if I don't get this assistance for housing? What if I miss the bus? How long will it take for me to get to these appointments? And we relate that to COVID-19 because of misleading information from the top, where we are getting our sources from, where we are being told to listen. And let's keep in mind, this is not the first time the President of the United States has undermined an epidemic, pandemic. You can use those words interchangeably, and I'll leave it at that. So with this misleading information and lack of communication, building that gap, you have to ask the experts where you're at and make sure you hold these people accountable to their words, because words continue to manifest actions. Ask those of lived experience. Hey, you go to this clinic. I'm thinking about going there. How is it? What is their turnaround time? What does their rapid entry look like? Find networks of people who are living the same experience as you. And I know that may be tough if you are not out about the experience that you are going to, but you gotta be able to, not gotta be able to, there are ways you can do that anonymously. Know the science, listen to the epidemiologist, listen to your doctor. I can say I have a headache right now, and Google it, and it'll say, well, you'll be passing away by 4:45. And to close off that, it is only so much emotions can do, because without action behind those emotions and educating yourself and surrounding yourself by people who can build you up from that education, that's where the action takes place. So allow those emotions to fuel that fire. And if you don't have that experience of speaking for yourself, find somebody that will do it for you. We call those rocket booster friends. Allow them to do that. That was my experience in Atlanta, Georgia. Now, moving from Atlanta, Georgia to Michigan, working in this field as an early intervention specialist, I am seeing not too much a difference from the deep South as far as disproportionate effects of HIV amongst Black folk. And the noticing of gentrification in the North and the South, that also affects homeless populations, because it adds to that. When you cannot afford where you live and you have to live so much outside of the limits of your day-to-day routine, that becomes another barrier. And the homeless population, not only in Atlanta, Georgia, but also here in Michigan, is continuing to rise. And mind you, prior to this pandemic, as Senator Kamala Harris, and former Democratic candidate, she said a pandemic does nothing but expose the health inequities before this pandemic arrived. So when we look at homelessness population amongst Black, queer individuals, same gender loving folks, trans folks, people who are marginalized because of their ethnicity, because of their race, and also because of their sexual orientation, that population suffers double time. Here in Michigan, education, there's not a lot of promo, there's not a lot of, hey, free testing here, free testing there, very minimal, but definitely shout outs to the Kent County Health Department and the Red Project, who get away with what they can. It is an abstinence-based school system, and there's a lot of misleading information. This is a very conservative town, and only certain type of folks get that, adding on to the stigma. Lack of community involvement. When you're in a place of privilege, if something doesn't affect you, you don't feel the need to take action for it. The lack of trust with the health department. There are historical health inequities that have been lived out through the health department, and trying to live that, to fix those experiences and say, hey, I turned a new leaf and this is what happens. We got to make sure that the receipts are there. The COVID-19 health inequities with testing and with treatment. We see that if you're rich and you have the access to 24/7 testing for your staff and for yourself, that is something that makes it a lot harder to believe. Me as a person only making $30,000 a year, why working two jobs? How can I get testing around the clock? And then treatment, if you're not bad off, they will turn you away and doctor you up to betterment from your home. And that just, it can only do so much. People, there's a lack of hospital staff, there's a lack of ventilators, as we are seeing. And representation, when it's a death or a scare tactic, it doesn't really work. But when we see the representation of those statistics of folks who are most vulnerable to this virus, now that has come up, when again, we've already faced pandemics before, and even during this pandemic, this can constantly be told by a lot of folks that COVID-19 is a hoax. They're very hush hush about it, again, if it doesn't affect them, or if they have the resources to put up a front, being very cavalier about their privilege. Next slide, please. Here are the best practices that I myself had to unlearn and relearn. And I have a quote here by Killer Mike. He is a Grammy award-winning rapper and a national advocate for racial justice. It says, "The way to start to break down systemic racism is to start building individual relationships with people who are not like you." Again, if you are not living this experience, it's okay to say, what can I do to expand the broader vision of the bigger picture to make sure that not only there is equality, but equity, cultural humility. Read stats, read books, fiction, nonfiction, listen to those lived experience, checking your own anti-Blackness, bias, and again, that honesty of not knowing and not being sure of what is going on. As Larry said earlier, self-care, unplug, make those connections the best way you can. Look what we're doing right now. We are connecting communities virtually. We are doing the work the best way we can. We have to make those connections outside of the work that we do too. Unplug from the work. Yes, the work does continue after 9 to 5, but we as advocates, as social workers, as healthcare professionals, we take the work home and we got to start listening to our advice. So let's not make HIV and the work, if you're living with HIV, the sole purpose of our identity and being. Let's have a kickback. Let's enjoy one another's company and just make sure the information is there, but that's not all that we harp on. Creativity, campaigns, support group, collective meetings outside of HIV focus as well. That kind of ties into innovative and non-traditional outreach. As you see, you could only get tested, and still can, if you have a certain amount of income and privilege and access to this testing. Now, the non-traditional way, getting the folks that's most effective, they have drive-through testing. Just as we have had mobile testing, nightclub outreaches, going to barbershops, getting $5 off a meal from a local business that will let us park there for 3 to 4 hours. There are ways that these pandemics mirror each other. And again, we have to be creative. We have to be consistent with the campaigns and support groups. Thrive does so well with getting, stamp of approval from Emory, getting on Jack'd, getting on Grindr, all these hookup sites, all these dating sites. They're able to let people know, hey, we know you're here for this, get your life, but also live your life and own your sexual health. And here's where you can get all that information from. Representation for the communities that you are speaking to. Have someone that looks like them, has that lived experience, and is really slaying at their intersection of their identities. Community-based and led interventions. Bring the community out, allow them to speak their voices. It is going to be very, very uncomfortable for some people, but hey, when you're uncomfortable, you like to move around. So me making you uncomfortable, light something in you to move around in the way that we can end these epidemics simultaneously or not too far behind one another, that's fine. I'll take that. Next slide, please. And to close this out, I, again, had to learn and relearn. And when you come from a place of privilege and not not being honest about that and not being honest of the thoughts that you had about certain people, whether it was your upbringing, TV, or just things that manipulated your mind to believe a certain thing. Here are some reading recommendations for people with that privilege, people who look like me, white folk, and they're actually all good books, so all people can benefit from them. But I'm particularly telling folks who look like me, read these books. Why Are All the Black Kids Sitting Together in the Cafeteria, and Other Conversations About Race. Rest in Power. This is a book dedicated to the enduring life of Trayvon Martin, happening in Sanford, Florida. This was a case that woke me up as someone from Fort Myers, Florida, County of Lee, 239. Shout out to everybody. I was a part of these nationwide marches, and seeing this case play out in my life, I couldn't allow that to happen again. So it is a very good book. Small Doses, Potent Truth for Everyday Use. Amanda Seals. She is a comic, she is a singer, she is a poet, and this is a lot of honesty with comedy. So you'll get the message, but you'll also laugh. And How Not to Get Shot and Other Advice from White People, D.L. Hughley. It is a very good book. There's a lot of statistics. There's plenty of comedy as well. And there is also a lot of recommendations for people to end racial injustice, from the prison to the school to prison pipeline to the Flint water crisis. Recommendations for people with living with HIV. Be your own advocate. By taking your meds every day, it could be as simple as that. Find someone who you can take your medicine with. Find something within you to manifest how to become an advocate. And if you're not there yet to publicly speak out, find advocates. They are all over the globe. You can find them at Thrive SS, He is Valuable Incorporated, Project Red Incorporated, PWN. We have so many people here rooting for you and also walking beside you that will not only shake, but stand on tables. I can attest to that. Share your story to the best of your capacity. You own every single right to your words. You own every single right to your name, because your word is bond. And now, my recommendations for medical providers. Please intertwine all of your years of education with the lived experience of having HIV. You went to school all those years, got all those letters behind your name, and I applaud you for that. But every single day I wake up knowing I have to combat this virus. And some people have to fight a lot harder than me. My name is Michael Lamb. Feel free to call me Miss Mikey. Thank you all so much for having me. Thank you, thank you, thank you.
Thank you so much, Mikey. I, talking about cultural humility is so important, and I thank you for, like, holding up that the simple tenet to cultural humility is just admitting that we don't know. And sometimes in those times, our clients, our members, our brothers and sisters, and others in community are the people who can inform for us what their realities are. Cultural humility is definitely super important, and thank you for that, as well as your art. Now to call up this next sister, if you were with us for the last Stronger Together conversation, you were able to hear the passion and the conviction of our sister, long-term survivor, Antoinette Jones. Jones is one of the ladies who prep. She's a part of the Ladies Who Prep tour, educating women, more specifically straight Black women, about the benefits of prep for them. She is a sexual health facilitator, as well as a peer navigator at Sister Love Incorporated, an international agency, reproductive justice agency. Antoinette has devoted her life to sex positivity as well as criminal justice reform. And without further ado, I call up my shero, Antoinette Jones.
Thank you, Larry, for that wonderful introduction once again. And thank you, AETC, for having me here again to present. Everybody can hear me well? Thumbs up. Sound good? Awesome. Okay, so as Larry said, my name is Antoinette Jones. Knows I am an HIV advocate in Atlanta, Georgia. I've been living in Atlanta for about 4 years now, and I got connected to Sister Love 3 years ago. where I became a facilitator of support groups, but that wasn't enough. So just um, meeting other organizations, diving into advocacy work, expanding my knowledge around linkage to care, around services here in Georgia, has allowed me to do so much more work that I didn't even know I could do. So, as Larry said, I am a long term survivor. I have been living with HIV for 25 lovely years. I was born positive. Some terms you may have heard around people who was born with HIV is a vertical or perinatal. I like to use those terms interchangeably. And then another term I like to use is serodiscordant. I will break down that word on the next slide. And then some of my positive experiences while living with HIV and aging had to do with the medical system and the positive advice that I've received from medical providers around managing my HIV care. Um, so as a result, I was called to do peer advocacy. I love science, so of course, improving anything around healthcare or science-based evidence is like what I call to be my cat's meow. So um, I'm grateful to be here, as I said, and we can go ahead and go on to the next slide. Next slide. Thank you. So I work for Sister Love Incorporated, and Sister Love is a nonprofit here in Atlanta, Georgia, where we do a lot of intersectional work around reproductive justice and HIV for Black women, expanding access to care for Black women, linking them to care, and those of marginalized community, marginalized folks who don't have access. So just incorporating the reproductive justice, how we define reproductive justice as Sister Love. Sister Love sees reproductive justice as the conditions of liberation that will exist when all people have the power and resources necessary to make their own decision about their bodies, gender, sexuality, relationship, families, and communities to create and choose their families and reproduce their communities as a whole. And I just want to bring that into the conversation, like I said, because um, when we're looking at improving or fortifying the healthcare system from an intersectional lens, we have to include reproductive justice, economic justice, social justice, and all of that in order to make the improvements and look at it from as one issue and not separate issues. Next slide. So some key terms, as I mentioned, serodiscordant in my bio. Serodiscordant means a mixture or a mixed status relationship. So like for me, I was born with HIV, my other siblings wasn't. We were all adopted and we all lived under one household. So it was a mixed status relationship. It was a serodiscordant relationship for us all. Long-term survivor. A lot of people do look at me and be like, oh, how are you a long-term survivor? You're so young. But it's understanding that although I'm young, I was born with HIV and I have been living with HIV for 25 years. And that is a long term. So there's a crucial need for more research around people who are born with HIV and the risks they acquire while aging. So when we talk about aging with HIV, we don't only want to look at those who are 50 and above. We want to make sure that we're looking at those who were born with the HIV diagnosis. Power and access, as mentioned before. Power access is the permission, liberty, or ability to enter, approach, or pass to a form or a place or approach or communicate with a person or a thing. And that has a lot to do with reproductive justice, having the access to certain things that we need for our healthcare, not just it being there, but how are we able to access it. And then, of course, like I said, intersectionality is a theoretical framework for understanding how aspects of one social and political identity, such as gender, race, class, sexuality, ability, etc., might combine with to create modes of discrimination. So like I said, not looking at things separately, but looking at them as one issue. Next slide. So the purpose of my portion of this webinar is, of course, recommendations from the HIV community for the HIV workforce to consider when providing continuing care services for people living with HIV, utilizing some best practices, messages, innovative approaches, and of course, advice around improvements in the healthcare system through an intersectional lens. Next slide. I also want to shed some light on self-care during this time, especially with the COVID pandemic. So just making sure that you take time for yourself. As was mentioned on previous presentations by Larry. So just making sure that you're taking time for yourself, doing everything that you need to do during this time to stay above flow. So if you have to take a break, please do. And if you can, extend that self-care to community care. So not only caring for yourself, but checking in on your neighbor. And I stress the word if you can. So if you can barely take care of yourself, don't try and take care of someone else. Understand that. So next slide. So getting right into it, identities who are greatly impacted by the challenges within the healthcare system. Of course, people living with HIV and advanced stage HIV, people with increased social determinants of health, specific to focus on race and class-based economic equality, so Black and Brown communities, Latinx communities, LGBTQ identified folks, people of trans identity, and of course, marginalized people. And then we want to also look at people with lack of access to comprehensive sexual education. Here in Georgia, we have an abstinence-based only sexual education. And the problem with that is that young people who need sexual education, who are very, who adapt well or receive information from their friends and peers, they need comprehensive sexual education from the school system that they can identify with, that is inclusive to all, that is judgment free, and that is comprehensive and advance and reflect science. So we want to make sure that people in rural communities, young people in the school system are receiving everything that they need in order to make decisions for themselves and have the information that they need. Next slide. So medical mistrust, we've heard this term a lot. It goes hand in hand with stigma, prejudice. So some medical mistrust just means the tendency to distrust the medical system and personnel believed to represent the dominant culture. Medical mistrust has been linked to failure to keep follow-up appointments, adhere to prescribed medication regimens, as well as a delay in health screenings. Medical mistrust is consistently higher among racial and ethnic minorities. So of course, African Americans reporting the highest level of medical mistrust. Next slide. Things that fuel medical mistrust. We want to look at some historical events, the lack of diversity that we see in research, past experiences, and biases from providers. And then on the next few slides, I'm going to break what all four of these things are for each of you. Next slide. So some historical mistrust, historical events that we see in medical mistrust. Of course, we know of the Tuskegee syphilis study. It was a 40-year-long study that included 600 Black men, 399 who had syphilis, and 201 who did not. Of course, we know that the participants were not treated fairly. Many of them didn't receive the treatment after this the research study, and there was no evidence to researchers had informed the participants of the study or its real purpose. We also see in the case of Henrietta Lacks, where she was a poor African-American woman who cancer cells was used by science and drug companies for decades without her permission. We see the birth control trials in Puerto Rico, where clinicians targeted poor and uneducated women to join clinical trials testing higher dosage of birth control pills on them with no informed consent and no regard for the side effects. And then, of course, forced sterilization on Native women. And we also see sterilization that happened amongst Black and Latinx women as well. So next slide. So lack of diversity in research. A lack of diversity in genomic research can limit the understanding of population-specific differences in disease risk. An example of this is the PrEP study. And we see that PrEP or pre-exposure prophylaxis is not for people who receive vaginal intercourse. So in the discovery trials, majority of the research was done around men who have sex with men and transgender women. And PrEP users portrayed, we also see that PrEP users portrayed on television ads or when we walk into the bus stops, anything of the sort, usually have well-dressed Caucasian men or just men who sleep with men. Next slide. And the problem with that is because amongst the US, women are at high risk of HIV. Most are heterosexual women of color living in low income areas without, once again, the word access to proper testing and treatments or places where HIV evidence is relatively high. Georgia, specifically Atlanta. So discovery trials issue is one of the negative aspects of the HIV field. Leaving out anyone out of this conversation is a problem, especially those um, at risk. So we want to make sure, or we want to at least thank Sister Love for the advocacy methods, where they are working with Gilead and to partners with discovery trials for women, um, to see how we can move those trials forward and be more inclusive to women. So yeah, so the solution in this case, of course, is that keyword advocacy. We have to advocate for not only ourselves, for others as well. So thank you, Sister Love, for that. Next slide. And past experiences. Past experiences has to do with your personal and past experiences related to the healthcare system. As was mentioned by Mikey on the previous slide, his past experiences from Georgia are definitely different than the past experiences he had in Michigan. His past experiences anywhere are different from my past experiences anywhere that I've lived. So by, like he said, find people with lived experiences, ask them, how was your experience, how was your appointment, is very important when deciding about providers. I know I've done that a lot, especially when referring people to my provider or to an old provider. They've asked, like, how's your experience with them, and I share it with them, let them know the pros and the cons, and let them make the decisions for themselves. Next slide. Implicit biases from providers. Once again, another keyword that goes hand in hand with stigma and prejudice. So an implicit bias or unconscious bias or stereotype is an unconscious attribution of particular qualities to a member of a certain social group. Implicit stereotypes shaped by experiences and based on learned associations between particular qualities and social categories, including race and gender. Biases is particularly well documented in pain management, especially with Black children and adults receiving less adequate pain treatment than their white counterparts in the emergency department for the same presenting conditions, even when accounting for insurance status or severity of pain. Next slide. So a real world example is, of course, the story of Tashana Ward in Milwaukee. She went into the emergency room asking for services because she was having chest pains, where she received the diagnosis of an enlarged heart. She was told to wait in the lobby for a number of hours. And once she was tired of waiting, because she was waiting for so long, she decided to go to an urgent care where she thought that she would be seen quicker. And she left, went to her car, where at her car, she died. And that is an example of us expressing ourselves to providers, letting them know that we are going through something and being ignored. So we want to make sure that we stay away from ignoring the voices of people, women who are expressing that they are in pain. Next slide. So the solution, once again, when providers approach clients or patients with implicit biases, they already have a pre-assumption about who the client is, who they think that the client is, and cannot provide the necessary care that the clients need. So making the assumption that Black and Brown Americans have a higher pain tolerance than their white counterparts causes a disconnect in the care that the Black and brown people receive. And it can lead in an increased distrust in the medical system, as well as an increased health-related deaths that go unsolved. So Black and brown people continue to believe that the medical system is out to kill them. And one thing I want to also mention is biases are reflective. They go both ways. Patients have biases about providers because of all the providers that we may have had in our lifetime. Like I know for myself, I've had at least 10 or more providers. I've lived in New York for a number of years in two boroughs in New York. I lived in Virginia, then I lived in Georgia. And I'm going from prenatal care yeah, prenatal care to adult care, into the care that I'm in now. So it's me switching providers so much. Of course, my biases change and I make false assumptions about providers. So we want to make sure that we're leaving our biases at the door before we go into our appointments. And then we coming in with the clear headspace and just being mindful of that. Next slide. So you want to be your own advocate. I know I heard Mikey say it, and I'm just going to repeat it for everybody. So you want to be your own advocate. Things you can ask your provider in your settings are exactly what your diagnosis mean. I have heard stories where people receive diagnosis and they were just sent out the door. I've been in facilitating spaces where I've asked people, what does HIV mean? And they couldn't tell me which each letter means. So being your own advocate, it just means diving deeper into your provider's head. Like, hey, explain that to me. And don't just explain it to me on doctor's terms. Break it down for the language that I understand and help me understand it better. Um, ask about further complications that you may experience related to your HIV diagnosis. What your weight actually means, your body mass, your fatty acids, and your water weight. Explain that what your test results are in depth, like I said, not just testing you, giving you your results and sending you on your way. As Sister Love, we take pride in doing that with our testing and counseling sessions. We don't believe in just testing somebody saying, hey, you're good, you're negative, you're non-reactive today, but we want you to understand why that you are non-reactive and what does that look like going forward and how you can remain non-reactive. So and if you do come back reactive, we want you to understand exactly what that means, how you can get in care, what does care look like, et cetera, et cetera. Wellness around pregnancy and how it's different for all people. Once again, bringing um, just some reproductive justice conversation into the space, especially with me being born with HIV. I want to highlight that and how, for myself, how pregnancy will look different for me living with HIV, trying to have a negative child. And then some natural remedies and alternatives. Ask about natural remedies. You never know what your doctor knows. It's very important. If you are someone who does not like taking medicine, have are burnt out by the medicines, then look at some natural remedy that you could possibly do to boost your immune system, especially during this time of COVID-19. Next slide. What I wish my provider told me. So, of course, more information about what the HIV medicine does to our bodies and the long-term effects of this medicine. As I mentioned before, there is not enough research for perinatal vertically born children who are now adults. And for me, I've been taking medicine my whole life. I went from taking liquid medicines to taking 6 to 8 pills a day, to taking 4 pills, to taking 1 pill. And all those different medicine classes, of course, my mind, my anxiety is like, what the heck is this medicine really doing to me? So, of course, having some more information, more research about how this medicine affects long-term survivors and the effects on our body. Further explain what HIV is, like I said, how it affects our body, future complications, and what future complications may look like, so that when we are over 50, and that research for aging with HIV is there, we are more than prepared because we have already been included in research studies, okay? Education around HIV criminalization, once again, as I facilitated groups, I've asked folks about HIV criminalization and what do they know, and some of them do not know anything, have never heard that um, failure of non-disclosure in Georgia can result in you facing up to 10 years imprisonment. So, um, and then also connecting me to resources. So mental health services, housing, support groups, um, that is some things that I wish my provider just automatically mentioned in our sessions. Just making me familiar with or know or making it known to me, even if I don't technically need those services at the moment, but at least saying, hey, how's your mental health? How where do you sleep at night? You know, that shows me that you are a provider who cares about me and my health. Next slide. What can be done? So, of course, like I said, having access to care services, and even if those services are virtual services, we see a lot of um, things like this webinar today where it's virtual, but it has so much information, key information that people need. Make sure you share this information with folks um, who may not have access to this type of knowledge and resources. So, virtual meetings, having access, like Mikey said, he had to take two buses and a train to just to get to his appointment. I have a similar story where I had to take two buses, two trains, or transfer on the train just to get to my appointment. That is not access. Having access if your provider offers a delivery service. I know my medicine is about to be here in a few because my pharmacy called me yesterday and was like, "Hey, would you like to pick up or get your delivery?" That is access. And I know I cannot get all the way to Decatur. So, of course, deliver my meds. And then so access is very broad, but at least it's there and at least we can obtain it. Implementing a form of telecare therapy as a way of expanding access to reach marginalized folks and people in rural communities. Very important. I just switched providers, as I mentioned. And the fact that my provider was like, hey, we're going to meet in person this one time, but then going forward, we will have telecare therapy because everything that is happening with COVID-19 is really up in the air. We don't know what our services or what our business hours will look like. So implementing that is very important. Providers, and this last key point is very important to me. So providers, please check in with your clients or your patients, especially those at higher risk of falling off their HIV regimen um, or known mental health challenges. So it takes 5 minutes at the most to call your client, call your patient, and just check in on them, especially if they have spoke with you or their appointment may be coming up. You've had to push their appointment back because of everything that's going on with COVID-19. So just picking up the phone saying, hey, I'm just checking in, seeing how you're doing. How are you remaining adherent to your meds? Do you need anything from me? Do you need any resource, any food banks? What do you need? Do you have any questions about your risk or your behaviors related to COVID-19? Um, do you feel like you need to be tested, et cetera, et cetera? So just going the extra mile to really connect with your patients during this time is very important. And like I said, like I highlighted, the mental health challenges. Even those who you don't automatically assume have mental health challenges, understand that during this time, we are in a forced isolation. So that increases our anxiety, increases our mental health challenges. So we just want to take extra care and community care for our people. And I think that's the last slide. Awesome. So thank you all
Yes.
once again. And I really appreciate you allowing me to share my own experiences with you all during this time.
Thank you so much, Antoinette. That was amazing. If you are listening to this and you have some things like Antoinette held up, things that she wish her doctor would have told her in this time, what are some of the things that you're telling your members, your patients in this time? And what is, if you're a person living with HIV, what are some of those things that you felt like your doctor should have told you, especially entering into this COVID space? It is with pleasure and pride that I bring up our next presenter, Justin Smith. He's a member of the Presidential Council on HIV and AIDS, PACHA. He is also the director of the campaign to end AIDS at Positive Impact Health Centers in Atlanta. And for the last 20 years, Justin has, in addition to working at places like the CDC, he has dedicated his research as well as his practice to focusing primarily on and involving the social determinants of health for Black gay men or Black queer men in general. It's with pride that I bring up my brother, Justin Smith.
Thank you so much for that wonderful introduction, Larry. And thank you to the AIDS Education and Training Center for allowing me to share some of my thoughts with all of you this afternoon. So I'll focus my conversation on thoughts about the HIV workforce in the current era of COVID-19. And I have three main things that I want to cover in my talk this afternoon. First is just to offer some thoughts about the ongoing need for HIV service provision during the pandemic. The second is to lift up a case study of one organization and how we have changed our service to continue to provide and meet the needs of our community. So I'll talk a little bit about what we are doing at Positive Impact Health Centers. And then lastly, I'll close out with some thoughts about the HIV workforce and what we and the HIV workforce can offer to the COVID-19 response as a whole. Next slide, please. So while I don't believe that I will have to convince anyone that is here on the call this afternoon that we need to continue to provide HIV services, I wanted to just spend some time thinking about why it is so crucial that we do so. And a lot of it ties back to that doing so attends to the social determinants of health. And much as we did in HIV, in the COVID-19 pandemic, we've already observed very stark racial disparities, and these follow patterns that we've observed in HIV. So while most of us that have been doing public health work were not at all surprised at the emergence of these racial disparities, they were still disturbing. And there's some really great papers that have summarized kind of the state of the knowledge that we have about these disparities. So there's a great piece in JAMA published this week by David Williams from Harvard, and then two other pieces published in the Annals of Epidemiology by Tonya Petit at UNC and Greg Millett, again, veteran of the HIV movement at AMFAR. So I encourage you all to take a look at those papers. What we also know is that, the same syndemic forces, and so when I say syndemic, what I mean by that are social forces that are negative and interact in a way that makes the others worse. These social forces that undergird what we know are poor HIV outcomes are really also at play in potentiating the spread of SARS-CoV-2. And so some of those things are the American history of chattel slavery, racial residential segregation, the lack of Medicaid expansion, reducing access to care for certain people, specifically those of us living in the South, employment discrimination, provider bias, as Internet sort of lifted up in her talk, et cetera, et cetera. Again, we know what these are. And so, we see these same patterns. And so I think it's important that we use this opportunity that is presented to us by the COVID-19 pandemic to really focus on these. And again, this is not new to any of us in public health, but what is different is I think that as a broader society, we're having these conversations about health disparities in a way that we have not previously. And we also know that while we have these mitigation policies in place around physical distancing, for example, a lot of people were thinking that, during this time, this means that sexual activity will decline. And while there may be some truth to that at the very beginning of the start of these mitigation efforts, we know that over time, people will kind of go back to a more business as usual type of model. And we also know that because of these underlying social conditions that are made worse by the pandemic, the need for ongoing HIV care and services may actually be exacerbated by this. So we have to continue to do our work. Next slide. And I think when we think about the HIV workforce as a whole, we know that due to the aforementioned socio-demographic, geographic, and environmental challenges that we know exist at the intersection of HIV and COVID-19, those of us that work in the HIV workforce are very likely to come in contact with people who have COVID-19 in the course of our work. So it is absolutely essential that the organizations that we work for provide adequate protection so that we can continue to do our work. Because we know that given that we are servicing a population who oftentimes are immunocompromised, and we know that uh, COVID-19 outcomes are poor for those who are immunocompromised in many ways, that we have to make sure that we are protected so that we do not serve as a danger to those that we serve. We also know that we as the HIV workforce are vulnerable to the economic impacts of the pandemic. We're staring at potential budget cuts in the not too distant future to critical infrastructure. And that's potentially going to have impacts on budgets of organizations. And so we have to think about how we plan ahead for some of those cuts so that we can still provide services to those that we need. And then also, while we think about kind of the psychological impact on the pandemic on those that we serve, we also have to think about the added psychological impacts and strains this might have on us as a workforce, both sort of in the short term, but also long term. And so I think some of the strategies that Antoinette lifted up earlier around self-care, some of the things that Larry talked about on self-care are really critical, but also it's important that we include in that a strategy, also seeking out professional assistance where needed, because I think this is going to have a very long-term effect on our mental well-being, specifically as we're those that are called to serve our community. So it's really important that we do all that we can to preserve our mental health. Next slide. I want to pause and shift a little bit and just talk a little bit about one model of how an organization has shifted to provide needed services during this very difficult time. So I'll talk a little bit about what we at Positive Impact Health Centers are doing. So we are a comprehensive HIV service organization based here in the Atlanta metro area. We have 3 different locations across the metro area, and we provide HIV care and treatment, but also do HIV testing, client services, so wraparound services such as housing. And we also have a robust behavioral health program. So one of the things that we have done to make sure that we can continue to provide these services is we've shifted to a telehealth model. So a lot of the services that we offer are now available in this telehealth platform. And that's allowed us to reach people in this time of need. And I think that this is actually an innovation that will persist post-pandemic. As Antoinette and Mikey mentioned earlier, for those of you that are not in the Atlanta metro area, both our traffic and our public infrastructure around transportation are sort of legendary in terms of how inadequate they are in a lot of ways. And so telehealth allows us to reach people that may have difficulty coming in for transportation to the centers to actually receive services. Obviously, we have to be thoughtful about differential access to internet and making sure that folks have access to broadband to be able to access these services. So that's certainly an ongoing challenge, but it allows us to continue to bring services to where people are. So that's a really important innovation. In terms of the pharmacy service that we offer, we've moved to no contact service. So if you come to one of the centers, they can bring the medication out to you, similar to how a lot of restaurants are operating in their takeout models. And we also do mail medications, and as Antoinette sort of lifted up in her talk, we're also doing 90-day fills to limit the amount of time that people have to come in and refill their medication, which can extend, which can make sure that people can better adhere to physical distancing and stay at home mandates that may be coming down from their state. We also have implemented a condom delivery service, so people can call in and request to have condoms sent to their house. And we're also planning to stand up a at-home testing program in the near future. We've also done things to try to make sure that we are supporting our employees. So really making sure that the staff know about employee assistance programs that can provide mental health counseling and additional wellness offerings, and also making sure that staff avail themselves of the numerous training opportunities that are available at this time, such as the webinar that we're all on today. And we're also, like many organizations and governments, actively planning for kind of what are ways that we can operate safely through the various stages of the pandemic. So really having this active engagement and planning, not saying that we're going to go back to normal, because we know that for many folks, the normal that we had didn't work. And so thinking about what is a way that we can attend to the exigencies of the moment, and make sure that we're being responsive to the needs of our community. Next slide. So I'll offer some thoughts now about the HIV workforce as a whole and what we, as folks who work in this space, can offer to the COVID-19 response. So as I talked about earlier, one of the things that we are certainly staring down at the face of is budget cuts. And so a lot of organizations will be thinking about how do we innovate to make sure that we can keep the doors open and serve the people that are that we're accountable to. So one thought I have about this is, as you know, one of the things that's been talked about as one of the keys to moving to the next stage in the mitigation efforts around COVID-19 is contact tracing. And contact tracing is certainly something that we in the HIV community have a long history of doing. Sometimes not doing that well, but we do have these skills and this ability. And this is certainly something that is needed in the broader public health sphere. So I think this is a unique contribution that we might be able to, as an HIV workforce, to have a big role in. And to kind of harken back to Larry's talk, we have a tremendous amount of experience in dealing with and managing stigma. And as we start to see folks come down with COVID and then recover and then sort of return back to their homes and to their workplaces, the potential for the emergence of stigma, we're already seeing that. And so I think that those of us in the HIV space have a lot to offer in how we can mitigate some of that emerging stigma, because we know that that's going to ultimately undermine mitigation efforts and also just how we deal with the pandemic as a whole. We also in the HIV workforce have been really called to lead literally in the COVID-19 response. So just thinking at the very highest levels of the response in the United States, two of the most visible figures in the coronavirus response in the United States have been people drawn from the HIV movement. So thinking specifically of Dr. Anthony Fauci, who is of course legendary in the HIV space in the US, and then also Dr. Deborah Birx, who led PEPFAR, the International HIV Program, for many years. So their expertise in learning from the HIV movement is directly being applied to our mitigation efforts in the United States. So that's one area. But then, on a more proximal level, when we think about what's happening at state and local health departments across the country, given that the coronavirus epidemic is, an infectious disease, and many of the people that lead on HIV are the very people that have been pulled to work on the COVID-19 response. So just thinking about in Georgia, many of the folks that work in the Department of Public Health, both at the state and local level, have all been pulled to do COVID work, especially those that are doing HIV. And that creates some challenges in terms of moving things in the workflow forward, because of the limited budgets, we're not able to backfill those HIV positions that have now been moved over to COVID. So while it is great that the COVID response is really benefiting from the expertise and the brain power and the know-how of our colleagues, we still have to make sure that we have people available to do the HIV work as well. And this last piece, I think, Mikey talked about in his talk about how much misinformation there is around. And I think there's particularly a large amount of misinformation about COVID in the community. So all the conspiracy theories that you see on Facebook, people will come to you and say, well, my cousin and, my friend from high school that I haven't talked to in 20 years posted this video, and it seems really interesting. Is this true? And we're getting a lot of those questions. So I think because those of us that work in the HIV space have oftentimes built a history of trust with the communities that we serve, we can really serve as that trusted source of information about something that is, frankly, really difficult to kind of wrap your mind around, right? So I think to the extent to which we can be trusted sources of information for our communities, that is really our superpower because we have that trust that's been built over years. So it's really important that we really deploy that trust in this moment where quality information is really essential. Next slide, please. So again, kind of looking ahead to the future, we know that the COVID-19 pandemic has wreaked havoc on the economy, and that is for sure going to have budgetary implications for sort of every industry. And there is no doubt that that will touch public health and HIV, even though I think now more than ever, people recognize and see the value and importance of public health more now than ever. But it's still, just because of the fiscal reality, there will definitely be cuts. And so we as organizations and those that work in the HIV space really have to think about how we innovate to make sure that we can keep our doors open. And as states move into more of these kind of open spaces, and as more states are kind of opening up and people are moving around more, we've got to figure out ways to make sure that the HIV workforce is protected, again, because we do serve potentially vulnerable population. We want to make sure that our folks are protected. And there are challenges with that because many of us are not hospitals, right? And when we think about the supply chains for PPE, who gets prioritized are going to be hospitals that are dealing with active COVID patients. And, so we have to figure out in that context, how do we still make sure that we get the things that we need to protect the folks that work for us? And that's really challenging, but it's something that is essential that we figure out. And then, to kind of harken back to some of the things all the other presenters have talked about in terms of self-care, this is going to be a long haul. So how do we make sure that we are taking care of ourselves so that we can stay in the fight and make sure that we're taking care of those that we're accountable to? So thinking about kind of what are those restorative practices that we can engage in a more regular way to make sure that we can stay the course. Next slide, please. And I'll close with this thought. And so I really love that Michael opened up his remarks with a poem. And so I will mirror that and close my remarks with invoking the spirit of our great poet ancestor, Essex Hemphill. And I think it's just important that, we remember that, as Larry said, this is not the first and last crisis that we've been through. And I think it's important just to remember that we are really a tribe of warriors and outlaws, to remember kind of the words that Essex lifted up in his seminal poem, In the Life. And, we are that kind of strong community that really comes together in the face of adversity. And we've been that since the dawn of the HIV epidemic. And so it's really important that we bring that spirit as we think about dealing with both COVID and HIV. We have the ability to do that. So thank you.
Perfect. Thank you so much, Justin, for that presentation and for holding up our brother Essex, one of my personal heroes. Here's Justin's contact information right there. Now is the part of the presentation where I will cover some of the Department of Health and Human Services guidance for people living with HIV. First, additional cautions should be taken for people living with advanced stage HIV or poorly managed or controlled HIV. Regimens, our HIV regimens should not be changed or altered in any way to include Kaletra as some form of pre-exposure prophylaxis for COVID. Don't do it. Don't change your medicines. Consider the risk versus benefit of going to and attending live appointments at this time, opting for telemedicine appointments, or maybe considering postponing appointments if you're a person who has sustained viral suppression, or again, try working out with your care team how you can engage some type of telemedicine. Trying as best as possible, as Justin as well as Antoinette held up, trying to keep at least 30 days of your medication on hand. If you can, if at all possible, getting 90-day scripts from your healthcare providers, making sure that your insurance providers will allow for this. A lot of insurance providers are allowing for their members to get access 90-day prescriptions to limit the amount of times we have to go to the pharmacy. If there is any switch to your medication due at this time, making sure that you monitor this close with your care team, to make sure that, like, nothing is going on at this time, making sure that we're paying extra attention to your body, how you feel, how this medication is making you feel, any side effects that may flare. And again, we repeat that additional cautions should be taken for people living with poorly managed or advanced stage HIV. If you attended the other calls, the other Stronger Together webinars, you know that I'm a proponent of lists. I am going to remind you on this call, as well as any other call, to make your list of all of your medications. Any medication that you take, make a list of that, as well as your care team, your doctor, your nurse practitioner, the nurse that helps you, your care facility, as well as a list of emergency contacts, people who must be notified if you are potentially hospitalized. And not only keeping this list in your side of your cell phone, which we all have our cell phones, many of you are probably on your cell phones right now, but also having a written version of this list that we place inside of our backpacks, maybe our wallets and things like that we keep on our person. Advice for people who are hospitalized with living with HIV, but hospitalized during this time of COVID. Making sure that we continue our medications regardless of if we're taken to the hospital or not, especially if we're taken to the hospital, or someone that we love in our networks are taken to the hospital, making sure encouraging them, as Antoinette and Justin, everyone on this call have said, to advocate for themselves. And if they're unable to advocate for themselves because they don't have the language or because they don't know what to ask, that we are advocating for their medicines to be continued when they are hospitalized. This happened several times in my family where people have been taken to the hospital in an emergency, and all of their other medical regimen is basically thrown out of the window. This is especially important if you're a person who takes the ebalizumab infusions every 2 weeks. These infusions are very important and they must be continued if a person is hospitalized. If you need some support around this, we have the patient support number for their patient support listed on the screen in orange. Please call them. They are available Monday through Friday. Let's make sure that we are maintaining our medical regimens. Here's some reassuring thoughts, positive vibes, what we like to say in these times, making sure that that we understand that the fear, the anxiety, and all of the angst that we're experiencing in this time is normal. It is a natural reaction to this crisis and the death that's happening around us, to make sure that we're providing a shoulder and an ear of comfort for the people in our networks, as well as ourselves, being nice to ourselves. Flashing back to our early HIV experiences, flashbacks to our early HIV experiences, and the death may happen right now, especially for long-term survivors who are aging with HIV, people who are around in the early HIV epidemic, understanding that we must create our services and our spaces in a way that is trauma-informed, that can help to deal with this. Making sure that we're taking steps to protect ourselves. One of the main ways to deal with that angst that is coming up right now is knowing that, hey, I wear my mask, I practice good hand health, I'm not touching my face. I'm also not only protecting myself, but I'm protecting my community. Seeing it as a personal charge actually helps me a lot. Understanding that many of us are feeling sad. confused, and all of these array of feelings that may rarely come up for us are coming up for us on a daily basis at this time. And to be good to ourselves, to be kind to ourselves, to listen to our bodies, to listen to our loved ones when they express feelings of angst and isolation and depression that may come up, not judging ourselves or anyone else in our networks because, a person wants to go out and eat, a person want to get some Jordans, a person want to get a haircut or thing like that. There's a way to remind and hold up for our loved ones that, hey, I want you to remain safe. I'm sorry, not remain self, remain safe within yourself. And I want you to take these precautions. But like when we feel judged, our blinders are on to whomever is speaking. We are no longer palatable or even open to their message. So let's make sure that we're not judging our friends and our loved ones, and that we're being nice, and that we're affirming that, yeah, these are weird, confusing times, but that we will get through this and that we will survive. Make sure that you're reaching out to the people in your networks, talking and providing space for us to talk through this, and honoring each other's feelings. This is the slide that we're going to close with today. Yes, thank you. Yeah, no judging. We remember, family will not be canceled. Friendships will not be canceled. Songs, your favorite song will not be canceled. Nina Simone will not be canceled. Reading will not be canceled. Pets will not be canceled. Community will never be canceled. Love cannot be canceled. And hope will not be canceled. A lot has been disrupted in this time, but we are still here. We're still together. And it's our mantra, and it's the truth. We're stronger together. So I would like to thank everyone of all of the presenters. We are entering into our question and answer segment. I would like to bring up the amazing Damon Johnson and thank the team from CTech. Damon is going to help us with our Q&A session right now.
First, I want to give all of you guys a thank you and a virtual round of applause. This was great. And from the comment box, I see that others feel the same way. But this is the time where I want all of you guys, I welcome all of you all to please list your questions in the question in the question and answer box and or comment box. I have two questions, and panelists, if you would turn your cameras on and your microphones. I have two questions that were very pressing and that stood out to me. One is, in all, what is the best advice to give to me as I'm a person living with HIV and need to be back in care but afraid of all this new stuff? I feel fine.
I can start. Just do it. Make the commitment to getting in care, understanding that being in care lessens our risk or improves our risk improves our chances of being virally suppressed, and that being virally suppressed actually helps us in these times. I know it's scary being out of care, and our bodies, though our bodies may feel fine, we don't know what's going on inside of our bodies. So that deserves and warrants the extra the attention to the HIV, and if you are struggling with linkage right now, you need some assistance with that. Anyone on this call can help. You can visit us at thrivess.org, and we can definitely help with that.
Anybody else like to take a stab at that?
I'll go ahead and say, just to kind of elevate what Larry said, definitely do it to the best of your ability. Definitely, everybody has a phone. Depending on what that phone does, you can access Google and make sure, support groups in my city, support groups within the zip codes, and then you'll be able to find people, or ask your doctor, ask your case manager once you get into care. But initially, you just got to find it within yourself, and hopefully it doesn't get to the point where you're I'm gonna say, yeah, sick or ill, and making differences in your longevity of health. So I'll definitely say, you got it in you. You just got to find it.
Thank you guys for that. Everybody mentions being an advocate. How do I be an advocate about something I don't understand? I just know I have, but I do not want to fight with people who are tired of people like me. Anybody?
I completely feel you. It's hard to advocate, especially when a thing is confusing for you? When I first was diagnosed as a person living with HIV in 2007, the last thing I wanted to do was advocate. I wanted to just be healthy. I understand that that's a normal feeling. I feel like the first place to start is by learning more. The more you know, the more you're kind of inspired to make a difference. The more the more the more equipped we are to deal with the pushback. And sometimes, and then also, advocacy doesn't necessarily look like this. It doesn't necessarily mean sitting on a webinar and speaking your truth. And maybe it's writing a letter. Sometimes it's just big up in your community, making sure that people in your community have what they need. It doesn't necessarily involve social justice advocacy. It could be just your own take and your own color of advocacy. I hope that helps.
Antoinette, would you like to add some feedback to that? I think we may have lost her. Okay. We have another question from a participant. Now that we have this new stuff to be linked, does it really work, or will this be another circular act?
Can you repeat that one more time?
Now that we have this new stuff to be linked, does it really work, or will this be another circular act? Essentially, what I feel like they're trying to ask is, now that we have new methods of linkage, will it work? Like, does the telecare linkages work, or is this just going to be another runaround?
Definitely on top of the work that's being done with telehealth and finding a new way to treat folks holistically, that comes with not only criticism but corrections. What's working, what's not working. Hand out surveys, like Antoinette said, as well as Justin. Be your own advocate and ask these questions. And if you're a provider, have general information looked up and how to access these new methods of wellness, whether it's virtual care, email, text reminders, the pharmacy calling you, and see how it's working by asking, the people you're giving this to.
Thank you so much for that. This is just a comment from one of the participants. I've been afraid because I've accepted my end was near after my diagnosis, but I feel I'm ready. I'm ready to take control after seeing all of you great advocates today. And I felt like that was great to offer to the space.
Ashe, that's powerful.
Thank you for sharing that. It's beautiful.
Any messages around getting back into care now that everything has shifted to Rona, which is coronavirus?
Just that is important. A lot of those barriers, especially, thank you, Justin, for presenting what the positive impact is doing, because a lot of the barriers that present themselves to people living with HIV, like the stigma, being stigmatized, going to a space, a lot of those are actually being erased, due to the advent of telemedicine. So maybe this is actually a good opportunity to engage getting back into care, especially to fortify ourselves against, the unknowns that are ever present with the COVID crisis. But it's just important to make sure that we, as people living with HIV, stop HIV with us, which is also, and that we're also able to live long, healthy lives with HIV. So, and if you need any additional support around that, we're here to support and help you.
As a young man, newly diagnosed, fresh out of high school, no one knows but my mom, but I really can't talk to her. What do I do? I've been diagnosed, but I have no help.
I can't sing the praises enough of peer support. Again, finding some sort of peer support. There are national networks of people living with HIV. It's definitely, and I can understand and identify with, having someone in your network that you can't, not living with HIV, who wants to help you, who can't really help you. Finding some sort of peer support, maybe going to a community-based organization, AIDS service organization, or again, some online support which we can link you to, would be beneficial at this time.
Anyone else?
I know for me, I didn't I didn't meet or find anyone else living with HIV until I moved to Georgia. So for 21 years, I didn't meet my first peer. I didn't meet my first peer until I was 21. And just with that, I know that all my life I wanted to, though. I was like, I just wish I can meet someone else who was positive, or I just wish my provider linked me to some sort of like support group service. So just ask your provider, reach out to them. Hey, do you know of any support groups that are welcoming to people like me? And then also like any online groups as well. So as you connect with people through those support groups, they connect you to other folks. And then you start to meet the family and then you're in the community. So just that.
And, speaking for, my generation and just, the average human being, Google, YouTube were like, even though they have their, downs, they do definitely have their ups. I would Google HIV support groups. I would YouTube HIV and, make sure I source the video and things of that nature. I found national campaigns. I found poetry. God rest her soul, Mary Bowman. I was introduced to her via YouTube, Kamaria Lafferty. And I just saw all these people affected by HIV, and I was like, wow, that's crazy. And I didn't meet my first official peer. Much like Antoinette, I was diagnosed in 2012, was dealing with it, lost my friend, moved from one city to another, and that was 2015. So yearning for that and seeing this intergenerational education and pouring into and passing of the torch, it was so refreshing and so it was like a revival, and I haven't stopped since. So, like Larry said, and Thrive SS can connect you to a support group of over 3,000 folks living with HIV, and it's truly amazing. Sister Love is doing their thing, so these places are out there, and use the World Wide Web to the best of your advantage and access.
Thank you so much for that. If I know someone who is on the infusion, they got better and was struggling to get it here now that they're in Georgia, will the number on y'all slide from this company be used to help? Larry, I could take that, or you can.
Go ahead, you can take it.
So the number will help, and we will connect you. If you reach out to us, that's something that we can give you that number again, and we'll also post the websites and the address. Someone asked about support groups. There are a number of virtual support groups. I know Larry at Thrive SS, they do a number of them, and I'm pretty sure Positive Impact does some. I know
Mhm.
in the DC area we have My Brother's Keeper. Oh no, Us Helping Us. I'm
That's
sorry,
helping us.
Us Helping Us. So it's a number
Mhm.
of places. So what we'll do is at the end of the call, we'll also be sending out a resource guide that we created that compiled resources all throughout the United States. We got representation from 19 states and one U.S. territory that will be included, and that'll have some information that you guys could really use to connect clients and your peers to. So stay tuned
Yes.
for that. Any advice, Antoinette? This one is to you. Any advice to people who work with vertical transmission, people living with HIV from vertical transmission?
Um, so the only advice that I have is just understanding that burnout is real. Um, and like especially for me, um, there's been multiple times that I've been burned out because I've been living with HIV for so long. I've been taking medicine for so long. I've been going to doctors for so long. Even today, like last time I went to the doctor, had my blood drawn, I started crying because I was just sitting there like, oh my gosh, how many times do I have to get stuck and poked and have blood taken from my body? Like, how many times do I have to go through this? So just keeping that in mind and just having compassion when working with long-term survivors, um, understanding that it's not easy. Like if we fall out of care, have some compassion, ask us questions, offer us resources, A lot of us are dealing with a lot of internalized stigma because, like I said, a lot of us have grown up in discordant families, where sometimes the family perpetuates stigma on top of us. So just being mindful of all of that, being supportive, being caring, is always very helpful, and being open to understanding, and learning as well. So you can learn stuff from people, from perinatal verticals. So.
Thank you so much for that. Justin, what lessons can we learn from the HIV epidemic blueprint and apply it in combination with our efforts to combat COVID post COVID-19?
So, so I think a couple of things. One of the things that we know we need in the COVID crisis is kind of actionable everyday steps. So let me say what I mean by that. So I think a lot of the guidelines that are coming out are around physical distancing, or like, oh, well, don't be in a group more than 10 people. So that still leaves a lot of questions about, so does that mean I can like go over to my boyfriend's house and have sex? Does that mean that I can go visit my parents? Does it mean I can have a dinner party with 4 people? Now that in Georgia especially, you can go get your nails done and a haircut and a massage, does that mean that I can go, do all these other things? And I think one of the things that we know from the HIV movement is that people need actionable harm reduction strategies. So when HIV first came onto the scene, there was communication around, using condoms. So like, and I think we haven't done a good job in the COVID response of providing people with those everyday actionable steps that, and we also know that, a lesson learned from, the HIV movement is that abstinence only does not work, right? And so a lot of what we're doing with the stay-at-home orders, well, I think they're important. It is the akin to abstinence only, right? And we know that over the long term, those types of things are not sustainable. And so one of the things that a lesson learned from the HIV movement that can apply to COVID is the need for more actionable everyday information that people can use in their everyday lives to navigate kind of their space. And so, one thing I think would be super helpful for someone to develop is sort of a risk continuum assessment. So we know that COVID is spread human to human through droplets, and so we know that there are certain environments where the risk of coming in contact with those droplets is greater than in others. So in much the same way that in the HIV space, we know that there are different levels of risk conferred to different sexual acts, for example. And so by giving people a sense of the risk, people can then make more informed choices about the types of activities that they may or may not engage in. And I understand that, it took us, 30 years to kind of have that level of detail to understand HIV risk. We're not there with COVID, but I think it's important that we start thinking about kind of what some of those tools and messages could be. I'll give a shout out to our colleagues at the New York City Department of Health and Mental Hygiene, who produced a guide to sex. And what I loved about this guide is that it was a harm reduction approach. So it did not assume that people are going to be abstinent from sexual activity. It started from the place that, it's like you're your own, your best sexual partner is yourself or someone that you live with, right? So acknowledging that, if you don't have a household sex partner, limit the number of people that you may engage with, right? And so it gave you actionable steps, so things you can do to minimize your risk, with the understanding that we're not necessarily going to be able to eliminate risk altogether. And so that is, I think, a lesson, and I know some of the folks involved in that, and they're also veterans of the HIV space. So that's one way that I think the HIV movement offers a lot to the COVID response.
Great response. And to your point, the next question is just about that. Any real advice on how to stay sane? I mean, we are human, and as you all have said, we need to be able to satisfy ourselves. That includes sexual tips. Any advice?
So as Justin said, like, your safest sex partner outside of yourself is a person that's in your home. And or that person that you can verify has been socially or physically distancing as well. So, yeah, definitely visit healthline.com. Actually has an amazing article with tips from medical professionals. Like if you're gonna have out real life sex, then making sure that you take precautions, having away from the body, away from the face sex, making sure that you wash before and after sexual activity, not sharing sex toys, especially dildos and things like that. Understanding that the presence of fecal matter can, transmit the virus. Anyone else, any other panelists have any sexual tips or advice?
Well, and I think to your point, Larry, that so much of this is the evolving. So I saw an article this week that they found presence of the virus in men's semen. So we don't yet know if that means that the virus can be sexually transmitted, but I think it will. That raises additional questions. So I think that what's difficult about giving advice is that we don't necessarily have strong data to sort of support specific recommendations. So this is hard, and I think part of what we as a scientific community and public health community, and I know if you're like anything like me, like your family's always asking you like, what should we do? And a lot of this is like we don't really know, and that's a really hard thing for people to say, especially in a time of crisis. I think some of the things that have been lifted up in these guides that do offer ways that you can minimize risk but not eliminate it altogether. And I think we have to be attentive to the fact that folks have different levels of risk tolerance, and we try to give people the best information that they can to make informed choices about the risk that they may be taking. But as the caller, the panelists, like the questioner asked, is that we're human, and so it is not sustainable for us to abstain from physical contact for long periods of time. It's just that is not how humans are built, right? And so I think that we're recognizing that, and we're trying to build out steps that people can take in the absence of a lot of good evidence to guide what we're saying. So it's tricky.
And just to add to Larry and Justin's really, really good points about, science, the stigma, ways of infection, those are really important. And a lot of people undermine those. But in this sense of time and social distance, well, not, yeah, with physical distancing and stuff of that matter, we all can acknowledge as public health workers, people are going to do what they got to do to get their rocks off. And I don't know about y'all, but before I came out of the closet, I was on the chat line, and now we got FaceTime, so we can have like virtual phone sex, and I can actually see what's going on. We can be innovative, and like Larry said, there's websites and places where it's like, hey, if you're going to do it, missionary is not the way to do it unless you want to wear a mask. We can role play that way. You just got to be innovative and still be able to have your sex drive be maintained, but also maybe this time could be for a little bit of downtime. Maybe this time can be for a little bit of more self-love in a way. Find other sexual experiences that, oh, I didn't know this could really work for me. And then I guess from COVID, make that connection.
Thank you so much for that. Annie also put in the chat box a very, very valid point that kind of piggybacks off of yours, Mikey. There are virtual sexual experiences available for people who have access to technology. There are movies that are integrated with sex toys and etc. So that's interesting. Also, you guys, we have our first two parts of Stronger Together that really Larry took a dive into some sexual health tips around COVID-19 and how to have sex. So if you guys want to, those are archived, and we'll send the links out to those as well. We know that we're about 6 minutes over. What I want to do is I want to give you guys back that time. But in the meantime, we ask that you please, please, please look at the links in the chat box and be on the lookout for our recap email on Monday. And it'll give you guys a chance to tell us what topics you want to hear from us next. And I think that's really important because there's so much chatter around COVID-19. People are about to be returning to work. There's a lot that's happening really, really, really fast. So we want to make sure that we meet your educational needs and kind of capacity post going back to work, because we don't just want to stop the training and stop the connection. So please complete the survey. The link has been added to this chat box. So follow that link. It's the future trainers request link. So copy and paste it and follow that link. And please let us know how we can continue to meet your educational and training needs. If you guys have a training request or further questions, please feel free to reach out to us. Yes, this webinar has been recorded and will be released. But thank you all, and it was great. Thank you to all the panelists. We truly appreciate you all. And we look forward to next time, guys. And remember, we're stronger together.
Yes, thank you all.
Thank you so much. Thank you, everybody.
All right.
Thank you, everyone.
Thanks, everyone. Great time. Thank you so much.
Investigation, baby, she was demonstrating, but nevertheless, I was free. My day was going great, and my soul was at ease. Until the Cooper brothers started bugging out, drinking the 40 ounce, going round, disrespecting my black queen, holding it crying.